Hi, TKC, and welcome to our second quarterly research brief. From research to reality, what a new hypertension paper means for teaching kitchens. Here's a question I'd like you to think about. If we already know what people should eat to lower their blood pressure, why aren't more people doing it? It's a simple question, but I think it's one of the more important questions in healthcare today, because we really don't have an evidence problem anymore. We have an implementation problem. And that's exactly why I wanted to highlight a recent paper published in Circulation called Culinary Medicine as a Key Lever in Hypertension Management. It's written by doctors Nicole Farmer and Jacqueline Albans. Nicole and Jacqueline are colleagues, longtime collaborators, and true thought leaders in food as medicine and culinary medicine. Both of these doctors helped shape this field nationally. What I love about their paper is that it doesn't spend time trying to define culinary medicine. Instead, it shows us. It takes a concept that can sometimes feel abstract and makes it real. It answers the question, what does culinary medicine actually look like in practice? Using hypertension as an example, the authors walk us through what happens when you move beyond telling patients, just eat less sodium, and starts to teach them how to do it, how to build flavor, how to cook differently, how to shop differently, how to feel confident enough to change lifelong habits. And that's culinary medicine. And honestly, I'd love to see more papers like this. Imagine one in diabetes care, one in the Journal of Clinical Oncology, one in gastroenterology, one in kidney medicine. Not papers asking whether nutrition matters, but papers showing clinicians what culinary medicine looks like for the patients they care for every day. And I think that's where this field is headed. So let me share 5 things that stood out to me as I was reading this paper. The first is that science isn't the problem anymore. The implementation is. We've spent decades building the evidence base. We know dietary patterns like DASH lower blood pressure. We know reducing sodium helps. We know increasing potassium helps. None of that is particularly controversial anymore. The question has changed. It's no longer, does nutrition matter? It's how do we help people actually change? And that's a much harder question. And I suspect it's one that many of you think about daily. Second, guidelines don't change behavior. People do. One statistic really jumped out at me. Despite the strong evidence base, fewer than 6% of adults with hypertension use potassium-based salt substitute. Why? Is it because people don't care? Probably not. It's because behavior is complicated and people don't know these products exist. They're unsure about the taste. Most of the sodium they eat doesn't even come from their salt shaker. It comes from restaurants. It comes from takeout and packaged foods. Have you ever found yourself thinking, if patients just knew this information, they'd make different choices? Most of us probably have. But this paper reminds us that information alone rarely changes behavior. The third thought is that this is truly where culinary medicine shines. The authors describe culinary medicine as the bridge between evidence and everyday life. And I love that framing because culinary medicine isn't just about nutrition education. It isn't just cooking. It isn't just behavior change. It's all of these 3 things working together. Instead of saying eat less sodium, we teach people how to make food taste amazing with herbs and citrus, garlic, spices, and different cooking techniques. Instead of saying, follow the DASH diet, we cook it all together. From recommendations to recipes, from evidence to action, and from information to confidence. And that's what we do in teaching kitchens every day. Or flavor matters. I don't have to say that to all of the chefs out there. Maybe more than we sometimes realized, flavor is a critical component. Most of my favorite parts of the paper focus on this beautifully simple point. Healthy food has to taste good. And if it doesn't, people won't keep making it. The authors describe practical techniques for building flavor without relying on salt. And I couldn't help smiling because I thought this is exactly what happens in Teaching Kitchen. We're not taking flavor away. We're helping people discover new flavors and we're teaching them how to build it. And that's a very different conversation. And finally, this paper isn't really about hypertension. It's about something bigger. This is about implementation. The authors described teaching kitchens, shared medical appointments, physician diet partnerships, virtual culinary medicine programs, and community education as ways to bring national clinical guidelines to life. That's a significant shift. Teaching kitchens aren't simply educational spaces anymore. They're becoming part of the healthcare infrastructure, places where evidence becomes practice, where research becomes behavior, and where recommendations become healthier lives. And I think that's incredibly exciting because it's exactly why so many of us have been doing this work for years. This paper simply gives the rest of healthcare a clearer picture of what that work looks like. So I'll leave you with one final question. If hypertension is just the first example, what is the next health condition that we should help flush out and publish on? What specifically do you hope will be the next endpoint to your case? And in a concrete way, how can culinary medicine improve patient care in that specialty? I'd love to hear your thoughts. Thanks so much for joining me for the second TKC research brief, and we'll include the link to the paper below.